Okay, so I think nearly everybody is in here now, so we'll make a start. So my name's Gail Mountain, and I was the principal investigator for the Journey Through Dementia study. And I've had a fantastic time over the last, I think, 4.5 years now. So my intention today is to celebrate with everybody what we've achieved over those 4.5 years, and to tell you the result, obviously, but also kind of have a good time around it. So this is what we're doing today. If you don't think you're doing that, perhaps it's time to leave now. I've known that before, people get into the wrong meeting. Okay, this is what we're here today to do. Is that all right with everybody? This has been a very big project. In fact, the budget was £2.1 million. So that's the scale of it. And of course, that means that we've had a lot of people involved. So our funders were the National Institute for Health Research, but also we've got all these other collaborators involved in this project. So it's been a big endeavour, and thanks to everybody. Okay. And just a disclaimer, what I say today won't necessarily reflect the views of the National Institute for Health Research. Okay? Everybody with me so far? So again, thank you to everybody, particularly who we call our experts by experience, people living with dementia, people with a diagnosis, and people supporting those individuals who've also really helped us with this project throughout, in particular assisting us to make sure that everything's understandable to everybody, and you'll hear more about that later. I'm sure we've got quite a few people here, haven't we? Yeah, scattered around the room. Fantastic. Okay, what I'm going to tell you now. Firstly, why it was important that we did this particular project. Okay. What it involved, the actual programme itself. Some of the people in this room did take part in the programme. Not everybody knows what that is and what we did. Okay, everybody? We know that following a diagnosis of dementia, which is a devastating thing for anybody to receive, then people ought to be then offered services to meet their needs. It's been a while coming, this kind of notion. In the past, and certainly when I started my career in research, the voice of people with dementia wasn't heard at all. Dementia wasn't mentioned in society. That's changed a lot recently. I think we're talking far more about dementia now than we ever did. We've still got a long way to go. The priority of the government to try and fill that gap initially was to make sure that people received a timely diagnosis, which people didn't in the past. And indeed, rates of diagnosis have improved across the country very significantly. But of course, now we've got people being diagnosed early, what's going to happen then? Well, people are going to say, well, what are you going to offer me now? Surely. Is there anything for me now? And that's the gap that we need to fill. As you know, there isn't a cure for dementia imminent. So the people are working very hard at this, and we all hope that's going to happen, don't we? Everybody in this room. But in the meantime, we need to think about the care and support and assistance people need to have or deserve to have in order to help them to live, us to live, I could be one of those people, who knows, to live as well as possible. Everybody's got a vested interest in this. Okay? Everybody with me with that point? Everybody agree with that point? Okay. To have what we call adoption in health and social care, we need to also think about the evidence. We need to generate evidence to demonstrate how beneficial programs are. No point people like me creating things, even with people with dementia, if it's not beneficial. So that's where we are. We need to be able to evaluate programs. Okay? And most importantly, we need to involve people with dementia in everything. Because what's the phrase? Nothing about us without us, yes? And we do believe that. So we wanted, again, through this programme to actually try and demonstrate that. Everybody okay? So what is this programme called Journeying Through Dementia? It was developed by people living with dementia around 2011, actually, told us the sorts of things that they thought should be available to people post-diagnosis in a consultation, certainly with my colleague Claire Craig. And taking that information, Claire and I developed a programme. So it's designed to help people to continue to live life. Challenge is, I think, in the past, when people got a diagnosis of dementia, they were then told to sit there, just do nothing, we'll do everything for you. What happens then to people? Nothing. Deteriorate, yeah, because if you don't keep using your skills, whatever they are, driving, whatever it is in life, if you don't keep using it, you lose it. So there's something what we call about excess disability that we can create in people. But also we can assist people to compensate for memory issues. We can think about trying out new things. People with dementia can learn new things. So we created the programme based in these ideas of continued independence, continued participation, doing things. And again, I'll say it's what people said would be helpful. So these are the sorts of things within the programme. The programme itself is delivered in a mixed way. So those people who experienced it understand what I'm going to say. It's delivered in a weekly group with other people with dementia. So people gather together and are facilitated to take part. So it's in a community venue, ideally not in an NHS venue. But unfortunately, we can't make it particularly local because people are scattered around any one area. That's a challenge. Also, people receive 4 one-to-one sessions with one of the facilitators. The facilitators have been trained by us to deliver this programme. So there's a mix of group meetings, one-to-one sessions, and going out into the community. So we're not running what we call a support group as such, though support is important. Talking together, sharing, sounds really important. The issue is getting out there with support from others to try and do the things that are difficult, which is a challenge for everyone, isn't it? In our lives, everybody avoids things. So the group provides the assistance that people might need to try those things that have proved difficult, or try new things indeed. We've provided this, what we call this programme, this manual, for people to work with, but it didn't mean to say that people couldn't suggest things that weren't in that manual. So that's another important thing. We didn't capture everything, and people had good ideas. Well, unfortunately, I can't bring any to mind just now, which is a bit annoying because we're writing the final report, and I should know that. But people did, in the group, suggest things that weren't in the manual, and it's the job of the facilitators to work with that. So at least 3 sessions should be out in the community, and that could mean just perhaps going to a local cafe. If, for instance, there was a cafe in this City Hall, then that would be an out-of-venue activity. We all went there. So it doesn't have to be a big thing. It doesn't have to be a big trip. And importantly, people who delivered the programme received supervision throughout. Normally in the NHS, and I've worked for the NHS, that's how it goes, you'd expect people supervising to have delivered the programme themselves. Not possible here because it's a new programme. So the research team in turn supervised them. A bit like Russian dolls, really. Kind of like a stacking thing. So, yeah. Everybody all right with what I'm saying so far? So that's what people received, or that was what was on offer. However, as many of you will know, this is what's called a randomised controlled trial. So that what that means is that we recruit people to take part, and then approximately half, the people are randomly assigned to receive the programme, and approximately half of the people that we recruit don't receive the programme, but they, in the same way as the people who receive the programme, they take part in, they assist us by completing questionnaires. I think we've got at least one person here who did complete questionnaires and didn't take part in the programme. Is that right? Yes. So could be said to be a bit disappointing if you kind of geared up to receiving the programme, but we need to be able to do this to compare whether people receive the programme or not, whether there was any difference. Does everybody understand? You hear about randomised controlled trials on the TV, don't you, for all sorts of things. So the main thing is to be able to compare those who got it with those who didn't. So everybody helped us, though. We couldn't, it was so important to keep everybody on board with this. We also did 3 other studies within the study. One was to look at how much it cost. You'll hear later, I'm not very good at explaining this, but everybody understands pounds, shillings and pence, but there's more detail here. How much does it cost compared with what is delivered normally? Do people stick to what we intended when they deliver the programme? So these facilitators, these people we train to assist people to take part, did they actually deliver it the way that we thought they should? Anybody facilitating here? Do we have anybody who facilitated? Okay. So there's a big thing about whether you did or whether you didn't. Having worked in the NHS, I'm going to stick my neck out a bit here, and it was quite a while ago. It's quite hard sometimes to stick to everything completely the way it was intended, I think. So we needed to find out that. We also wanted to hear what people thought about taking part. So it's all very well completing questionnaires, and some of you in here have done that, but that doesn't give the full picture, does it? We want to hear people's views, ideas, experiences. So we interviewed a number of people who took part, and again, you will hear about that in detail later on. So those are the things that we did in this big project. It's all gone really quiet. I hope that means it's interesting rather than it's boring. Don't know. You'll tell me if it's boring, won't you? Who could take part? We had to have people with what we call a confirmed diagnosis of dementia. People who've been through the diagnostic process will know there's quite a lot of uncertainty in some aspects. We had to be sure. So we had to have something from the medical team to say that, but also we also tested people using a screen to actually just make sure. So everybody had to have a diagnosis of dementia in the earlier stages of the condition, because this is what this programme is designed for, not for people later on in the journey. People had to understand English. It's a bit challenging, isn't it? We live in a very diverse society, but I know if we started this programme perhaps with people who didn't understand English as well, we'd make it more difficult for ourselves. The next job is to tailor to different groups. So that's why. We just hadn't got the resources to extend to people. But interestingly, I don't think people came forward from such groups, but we could talk about that later. Also not taking part in any other research, because that kind of messes the results up. As you'll know, in this programme, we also recruited what we call participating supporters. So not everybody who took part in the programme actually had a supporter. It's important. And that was one of the things that was important to me, that we developed a programme that could be accessed by people without support, because not everybody does have. But those participating supporters were people nominated by the individual with dementia to take part. And we also we involved them, but they also had to be able to understand English. The number of people that we required, now, we had to take into account people withdrawing, dropping out for various reasons. Because people do. It's life, isn't it? Life happens, doesn't it? So we ended up with a figure of, we needed 486 people to take part in this study. Everybody okay so far? Well, I'm going a bit slow. I don't want to hold up the hot coffee break, but okay. Now, these questionnaires then, what we call in the scientific community outcome measures. And some of you are smiling because you know what that means. It's a bit arduous, isn't it? And we really appreciate the time and effort that people put into helping us with this. The main measure that we wanted to look at really was well-being in people with dementia, because that's what policy's trying to get us to do, to help people live well with dementia, live as well as possible. Unfortunately, there is no such measure of well-being in people with dementia, so we measured quality of life instead, which arguably isn't quite the same thing. To actually complement that or supplement that, we actually chose a range of other measures as well to try and reflect life, daily life. So we had a measure of what we call positive psychology, which is the flourishing scale. We looked at activities of daily living, whether people were still able to carry out the things they needed to be able to do. We looked at people's self-management, ability to be able to manage themselves and perhaps deal with their symptoms, compensate for their symptoms, for example. We looked at anxiety and depression, but that was really not for the study as much as be able to identify anybody that was in distress that we'd recruited and to be able to signpost them back to services, to be honest. That was less to look at any changes, more to actually make sure that everybody was okay. Else I'm liable to, self-efficacy. In other terms, confidence. Being able to sort of say, well, this is what I'm doing. Self-efficacy, is everybody? Yeah. So it was, the measures reflected that. Unfortunately, not all the measures, well, only one measure had been designed specifically for people with dementia. The others just do not exist at the moment. So we had to use the best that we had. And I'm sure I'll hear some views from some of you about what it was like, both people who completed the measures and those people who tried to administer them with people. But this is where the science is at the moment. And the supporters, we asked them to look at their, what we call sense of competence in being a supporter, how confident they were as well. Okay, so the questionnaires were completed at the beginning. Okay, if you remember, these people that did take part at the outset, what we call baseline in the trade. So at the time you were recruited to take part. Then about 8 months later, so it should have been when everybody sounded like Santa. So I thought Santa was coming in there with the bell. Yes. 8 months. I thought it might be a bit of a distraction. We should have done that, actually. Okay, so about 8 months later, and that was what we call the main outcome. That was the most important. And then again, 12 months after that. I have to say, everybody stuck with us really well. It was fantastic. No, it was arduous. I appreciate that. And both the people collecting the measures and the people completing them really stuck with us with that. So we're really pleased. The bizarre thing, of course, was that the researchers weren't supposed to know whether those people that were taking the measures from the questionnaires had actually got the programme, or the people that were just helping us complete the measures. Occasionally, of course, people would say, it's difficult, isn't it? How can we get this? It's what we call blinding for people who are interested in that kind of thing. Or they blind to whether people receive the intervention or not. The idea being it could bias the way you complete it. Of course, we got reasonable results there, but you wouldn't have expected any better, would you, really? Because people are bound to say, I did this, I did that. It's difficult, isn't it? Okay. People with dementia involved us in the study throughout. We had a study advisory group, which were essential to us to make sure everything was understandable. And we're still using those people now to make sure that our outputs are understandable. And also somebody called Wendy Mitchell, some of you will know, was a member of what we call our trial steering group, which is a governance kind of committee to make sure that we as researchers were doing everything that was the way that we're supposed to be doing it. We weren't going native or anything, but to stick to what we said we were going to do. You'll hear again more about that later. Okay, so Any quick questions now at this stage? Where the time? We'd like to carry on to the results. What did we find and how much did it cost? Okay, and this is what this presentation is going to tell you about, who took part, what they did, how we kept people involved in the study, particularly those people who were filling out the questionnaires, because it can be seen as not being as rewarding, okay, and the results. So 480 people were actually recruited to take part in the programme. It just fell 6 short of the number that we wanted, which was a bit frustrating, but still it was a fantastic achievement on part of everybody who both recruited those people and volunteered to take part, that we got that many people. It took a lot of effort. As you can see, the breakdown of those who received and those who didn't receive the programme. And 350 supporters as well. That's a lot of people. Okay, this just very quickly, I won't dwell on this, details the different sorts of diagnoses that people had who took part. And as you would expect, the majority of people had Alzheimer's disease because that's the most common form of dementia. Okay? Where did we get these people from? Where did we encourage people to join us from? Memory clinics, 16%. Join Dementia Research Database. The voluntary sector, kind of different charities, butterflies in Hull, I can think, and that kind of thing. There's different charities in different places, not just the Alzheimer's Society. It depends, doesn't it? Primary care and others as well. So a range. Okay, where did it go? Where did we work? 13 sites across the Midlands and the north of England. Again, we've got representation from those sites. Quite a number of those sites here, including, of course, Bradford and Sheffield. What they did, I've explained this, okay, so about the 12 sessions, group sessions, the 4 one-to-ones. Now, almost predictably, I'd say, the numbers of people that we got grouped together wasn't the number that we'd calculated on. Almost I could have predicted that, to be honest, but we get a very optimistic view sometimes in research that we're going to be able to do it, and it was difficult. So the numbers that we got were averaged 5 in groups. Maybe, I think some of the facilitators would agree with me, 12 would be too many anyway in any group. So it's one of those things, really. So we got about 5 on average, though we did get bigger groups than that, we got smaller than that. The attendance was really good. Again, as an OT by background myself, my experience tells me that this attendance was better than you would get normally in service delivery, which was interesting. So once people were in, the message they were in, if you like. Obviously, taking into account illness and whatever else, with life, as I said. And again, the one-to-one meetings, not as good as the groups, but still pretty good. So these were generally in people's own homes or in the community, and were about individual goal setting, what people wanted to do themselves, the opportunity to have that one-to-one with a facilitator. So this is the attendance. What did people do? I mean, again, people here could tell us what they did. A whole range of different sorts of activities. The programme itself is designed to, firstly, people choose a topic, whatever it is. It might be maintaining memory or whatever. Then there's some kind of discussion around that topic. This is the plan anyway. Won't always work like this. Then people are encouraged to do some practical activities in the location around that topic. Then it should culminate then in going out and relating that to life in the community, life outside. So you can see all sorts of things, and I'm sure we haven't collected everything there. So this was actually in the venue. What about outside? Well, all sorts of things that people did there, out in the community. Maybe people recognised some of those things. Again, it's difficult, isn't it? So going out in the community will be a different challenge for different people. For some people, it might mean trying to manage money. Other people, it might mean having to get on a bus or having to walk with a mobility aid outside. It could mean all sorts of things. So we're bearing in mind the individual challenges for each person. Keeping people involved, we were really pleased that we got 6 short of our recruitment target at the outset, but we managed to make up ground then, because when we got to the 8-month visit where people completed the questionnaire, we got the numbers then that we wanted bang on, actually, and that would have taken into account 486. So there was great celebration at that stage. We're really pleased about that. And again, a 12-month visit, we managed to keep people in this study really well. So again, the good thing about once people were in, they were in. Is everybody all right so far? Everybody's with me? Okay, so here's the results, and you may know this already. Unfortunately, but almost some of me said this was likely to happen, there was no significant findings between the people who took part in the programme and those who did not on the main outcome measure, which was dementia quality of life, what's called the DEMQUAL. Okay. So what we predicted was, I think about, I should know this, I think it was 4-point raise, and we got just shy of a 1-point increase in people on the DEMQUAL that took part in the programme, as opposed to those who didn't. Disappointing, isn't it, everybody? I built you all up, now I've pulled you all down again. Don't think like that. It's all work in progress. You can see it there. You can see it clearly there in that bar chart. Before and after, both the intervention and control. Okay, everybody? The other questionnaires showed similar results, apart from one, which was the Diners Flourishing Scale, which was this idea of people feeling good about themselves. And that did show a significant difference between the people who received the intervention and those who didn't. I have to be careful here, because the statisticians tell me that could be a random chance. But I'm feeling maybe it wasn't, but still. Okay. Okay. Costs as well. It's complicated calculating costs of anything. So it was said that this programme cost £609, which is more expensive than usual care. That's not, for me, taking into account the fact that people turned up to this, whereas I know in usual care people often don't turn up for things. Maybe that's changed, maybe I'm being unfair, I don't know. But they used to in the past, and it used to turn up. So, did that take into account that? No, it didn't. So, that's it. Now, it feels a bit glum in here now. And I don't want you to feel like that, because what we're doing is going forward. This is work in progress. These sorts of big studies are still fairly early days. We have a lot to learn yet about what people want and when they want it, I think. But also we have a lot to learn about how to measure properly, I think, what people get. And that's a big sticking point. Yeah. Okay, so this is Jules Beresford-Dent, who's worked as a researcher with us in Bradford on the project. So really pleased that Jules been able to present this work that she's been conducting with Kirsty Sprange from Nottingham.
Yeah. Okay. Cool. Yeah. Okay, we'll make a start. Thank you, everybody, for your time and attention. We're just going to talk a little bit this morning about the qualitative one-to-one interviews that we did with people as part of the study. And as Gail said earlier, this is an opportunity to find out what people's experiences were of actually taking part in the Journeying Through Dementia programme. Both as a participant, as a supporter, but also as a staff member that was involved in delivering the programme to people as well. Okay, so why was this important? So we wanted to understand what people had experienced through being involved in the programme. So we wanted to actually sit down with them and ask them about that on a one-to-one basis. We also wanted to get some context to the data that we'd gathered from the outcome measures from the questionnaires that Gail talked about, and doing interviews with people is a good way of doing that. So what we did, as Gail mentioned before, we had almost 500 people taking part in the programme, and it clearly wouldn't be practical to invite all of them to come and talk to us. So what we did is we invited 4 of the NHS sites that were taking part in the programme, there were 10 at the time, to work with us to do this piece of work. And that would entail the staff at those sites being invited to take part in the interviews, and also the participants attending the groups and their supporters, if they had them, they'd be invited to attend as well. So that was what we did. In terms of the sites, we had a mix of sites in terms of location, and also in terms of including more rural sites and also more urban sites to try and get a mix. And to do the interviews, we had a list of questions that we were going to sit down and ask each of the people that were going to take part in the interviews. And those questions and our approach to the interviews were developed with our Experts by Experience group that Gail mentioned earlier. So a group of people that were either people living with dementia or caring for someone living with dementia. So they could help us make sure those interviews and the questions we were going to ask were accessible for people. So in terms of who took part in the interviews, I won't go into the full detail, but we had 15 people living with dementia. We had 10 people that were supporters to those people, and we had 15 staff, and the staff included both facilitators and the staff that were supervising the facilitators as well. So what did we do with the information that we collected in those interviews? So there was 2 steps to the process. We took the information that the staff shared with us and we analysed that separately, looking at what those staff members had told us. And then we took the information that the participants and the supporters had given to us and analysed that separately. And then what we did is we brought that all together, and we were particularly looking for, although we'd asked them slightly different questions, what did people agree on? What were the things that they were saying that were consistent and the same? But importantly, what did they disagree on? Where there were differences within that information? And from that, we found 3 main themes. We've been working on this piece of work for over 2 years, so you can imagine the volume of data that we collected through doing all of the interviews. But what we've done to make it accessible is bring that down into 3 main themes that we're going to discuss with you today. So as you can see, the first theme is preparedness, or being prepared to take part or deliver the Journeying Through Dementia programme. Theme 2 was about how people were able to engage with the programme, either as someone receiving it, as a participant, or as a member of staff delivering the programme. And then the 3rd theme, perhaps most importantly, is what the outcomes were for the people that actually attended the programme. So I'm going to go on and talk about each of those in turn. So the first theme is preparedness, and what we meant by preparedness is how prepared both the participants felt for attending the group and one-to-one sessions, and how prepared the staff felt for actually delivering those sessions to the participants. So people told us that they recognised and valued the innovation of the programme. Particularly, people valued that it was delivered in the community, and also that it was person-led. So people living with dementia were very much involved in choosing the topics that were discussed at the group, identifying outings that they wanted to go on to. But at the same time, some of the staff told us that that did create tensions for them in terms of how they were able to deliver the programme. And they particularly mentioned their duty of care. So the staff delivering it were employed in the NHS, and for anyone that's worked in the NHS, which I have myself for many years, there is a big focus on managing safety and duty of care to people that you're responsible for. And that did create some tensions for the staff in terms of how they could uphold that responsibility whilst being out in the community with a person-led intervention. So that was one of the things that they told us. And then in terms of preparedness again, people told us that meeting everyone's needs in a group session was quite challenging. And that's probably not a surprise. We're all individuals. The people attending the groups had individual preferences, personalities, individual capabilities. And that proved quite challenging to actually try and meet everyone's needs within that group setting. I think also because of the nature of the programme, because it was multi-layered, it was discussions within a venue, speakers were invited in, so there was quite a lot of coordination of inviting those people to come in and speak, doing outings out in the community. It was a multi-layered programme, and I think that presented some challenges for some people as well. And in terms of the participants, the people attending, their cognitive and physical abilities, quite a broad range of people attending, which again was quite challenging to meet all of those individual needs. The second theme that we're going to talk about is engagement with the programme. And I just touched upon cognitive ability of participants. That did affect their ability to process the information that was being shared within the sessions, and also their ability to remember and retain what had been discussed in the sessions. So that had an impact on how useful it was, what they could take out of the sessions, what they could take forward. So I'll just move on to the next slide. The ethos of Journeying Through Dementia was that it would be delivered in the community. We specifically asked that the groups wouldn't be held in NHS buildings. I think things like church halls, village halls, libraries, that kind of thing was encouraged. But what some of the staff told us is that was actually quite challenging to organise. Some of the reasons they gave us is those venues weren't available within their locality, so they weren't accessible for the people coming to the group, or that there was costs attached, and that was a bit of a barrier for people. So our ethos of it wanting to be in the community was sometimes quite challenging to deliver. The other thing that people told us, and this was both participants and staff, is that people actually quite like coming to NHS venues because they're familiar and they're set up, they're geared up and accessible for people living with dementia, and they also were private for delivering the group. So whilst we wanted to deliver it in the community, some people actually preferred it being delivered in an NHS venue that they were familiar with. Another big theme, a big kind of like area coming out of this theme was transport. I think almost everyone that we interviewed in some form mentioned the challenges of transport, which again is perhaps not a surprise. The ethos of the programme was that people would organise their own transport. They'd make their own way or get a lift from a family member, for example, to come to the venue. But in reality, that wasn't always possible. And we've got some quotes as we're going through in terms of what both participants and staff said about different aspects of the programme. And for example, the participant at the start here is basically saying, if you hadn't been driving, I think I should have had to pulled out altogether. And the facilitators kind of echoed that if assistance hadn't been offered with transport, they feared that some people wouldn't have been able to carry on attending the groups. So sometimes they stepped in and offered some assistance with transport. So in terms of the mix of people that were there, we mentioned before that there was a wide range of people attending the different groups, different abilities, different backgrounds, ages, genders, and so on. And for some people, that was seen as a strength of the group. They quite liked meeting people from different backgrounds and with different experiences. But for others, they found it a limitation in terms of how well they felt they could connect and bond and form friendships with those people. So just moving on to the third theme, which is outcomes for people attending the programme. Most, if not all, of the people that we spoke to did value the social contact, and I think this is something that stood out across all of the interviews, that people really valued the social contact that was generated through going to the programme. Relationships between participants, relationships between the people facilitating the group and participants, they were seen as really important and significant to the programme. And people specifically mentioned the importance of the supporters where they were taking part in the programme in terms of the role that they played in enabling people to get to the programme and take part in the programme. So relationships were really important. People also told us that the confidence had increased, and some actually mentioned specifically that as a result of going to the group, they felt their anxiety had reduced, which clearly is, a very positive thing. And some people spoke about having a common experience, being in a group of people that they had something in common with. They felt the acceptance that they experienced was positive, and also provided some reassurance of the situation that they were in terms of living with dementia. So carrying on with outcomes, some participants actually spoke of activities that they'd rediscovered through attending the programme. So one participant here talks about prior to going to the group, they hadn't had the confidence to swim, but through going to the group, that was something that they'd actually re-engaged with. And also spoke a little bit about, what they anticipated the group was going to be about, bingo and nostalgia. But actually that isn't what they found, that it wasn't just about talking about things, it was actually going out and doing things, which was an important part of the ethos of the programme. So that's reassuring that some people experience that. So just continuing with outcomes, supporters that we interviewed actually told us that they benefited from meeting other supporters at the group. So just to explain, the supporters that were involved in the programme, they had the opportunity to attend 3 of the group sessions. Not everyone took us up on that, not everyone did that, but for those people that did get involved with the group, they spoke about the value of meeting people in a similar situation to themselves and learning for themselves from those people. However, some of the facilitators also told us that having the supporters involved, sometimes because they were protective of their loved ones, it did form a bit of a barrier for them being able to undertake certain activities with those participants. But also the facilitators spoke about the importance of the supporters being involved in the programme, again touching upon enabling them to get to the group either through transport or prompting them and reminding them about the group so that they could engage with that. So a bit of a mixed picture really in terms of what supporters got out of it and how that worked. So I suppose that's the most important slide, isn't it? So what? Our work has surfaced some positive aspects of the Journeying Through Dementia programme, but it's also raised quite a few questions and issues really in terms of how we deliver this kind of programme. And we're hoping that we're going to be able to open this up for discussion. There's an opportunity for questions at the end of this session. So thinking specifically about who benefits and how they benefit. Is this kind of programme about the here and now, or is it more for the long term, thinking about people who have cognitive impairment, their ability to retain things that are discussed and learnt within a group setting, and how we meet everyone's needs when dementia, as we know, is a very individual journey, trying to bring people together in a group and attempt to meet a mixed group of people's needs. It raises a question about how supporters should be involved. They've clearly played a very important role in supporting people to attend the programme, but how do we make that work best for everybody? And is the NHS ready for a programme like Journeying Through Dementia? The facilitators told us that delivering the programme was innovative. On the whole, they enjoyed it, but equally it took a lot of time and it was resource hungry. So are we ready for this kind of programme? And how do we manage challenges such as transport and community engagement when we're aiming to deliver things in the community? How can we best do that? So that's the end of the slides. If anyone's got any questions immediately, I can take those, or indeed there's an opportunity at the end of this session for questions. So any questions now? No? I'm going to hand...
There's one here, Jules.
Yeah, sorry.
You mentioned transport there. There's an access bus that if you join the access, they'll take you. My husband goes once a week for 4 hours, and the access bus picks him up and brings him back. And then to a wellbeing cafe that we go to, it's only £4 each way for a taxi.
Brilliant,
well,
yeah.
you get so much a week to to look after them.
Yeah.
I know you're not supposed to pay taxi fares out of it, but if you haven't got a bus route or a car,
Yeah.
that is the answer. And it's only £8, and you've 2.5 hours of entertainment. It's worth it. And as I say, the access bus that takes him to the one that I don't go to, it's only £10 for the day for a lunch, a breakfast, and the access bus. Again, it's only out of your allowance that you get every week.
Yeah.
That's how I look at it.
Yeah.
Whether I'm unusual, I don't know, but that's how I look at it. That money that we're giving to care for them is helping to care for him to go out.
That's
Thank
brilliant. Thanks for that point. I think some of the people that struggled particularly with transport were those people that either lived alone or indeed those people that lived in more rural areas. And some people did indeed use the access service, but some people found that it meant that they either missed the beginning of a group or they had to get there really early because the groups were at set times each week, that it didn't always tie in. So for some people, like yourself, it worked brilliantly for them, but for others, that didn't seem to be a workable option. Brilliant, thank you for that. Thanks very much. Okay, so I'm going to hand over to Michael and to Claire, and they're going to talk a little bit about how we involved people with lived experience of dementia in the study.
Hello, so this is, I'm Claire Mason, and I work with our experts by experience who have been involved in the project throughout. And Michael here is one of the participants in the study. And Michael attended all 12 sessions of one of the groups that took place, and he's going to tell you about his experience now.
The thing was, when I got diagnosed, I wanted answers. I wanted to know what was going to happen, what changes needed to be done. They put me in a group, and I absolutely hated it. I used to go on a Friday. You weren't allowed to mention dementia. You weren't allowed to mention your illness. And they used to say to you, right, throw the beach ball, catch it, and then say your name. And I thought, well, these are all in their 80s and 90s, and I was 57. And I thought I shouldn't be here. And then I was getting depression. I then went isolation. I didn't want to go out, didn't want to mix with people. And I thought, is this it? Is this my life? And then the memory team says, there's a research coming up, journeying through dementia. Would you be interested? So I thought, well, yeah, it gets me out of this other one. Totally different. As soon as you got there, they had a different policy. The minute you got there, they would say to you, would you like a tea or a coffee? Well, yeah, I'd like a coffee. Okay, we'll show you where the kettle is. Basically, it's basically you've done it yourself, because I have learned there's this thing, use it or lose it. Don't keep doing the things, you are going to forget how to do them. That was actually a good policy with them. Oh yeah, they brought people in from other organizations, other groups, would talk to you about how to get out in the community, how to do things, basically to get back into living again, and basically you were part of the community. I mean, one of them, they brought in somebody from Age UK, and I actually finished up doing a basic IT course. Because of the isolation, they taught me how to get on the emails, how to get on the Facebook, so I could interact with family and friends and still carry on living. We're basically encouraged for healthy activities. I finished up joining a walking group. I started getting out more. I started using trains, public transport, started going to places I'd never been before. And through the group, they actually took us till Cliff Castle in Keighley, which I didn't even know existed until they took us.
They didn't tell you what to do, did they, in the sessions?
No. You actually picked your own subject. They would put cards down and they would say, say you were having an issue, like a memory, it would be on one of the cards, and then people would pick it, and then that was the topic what was used. and then you just had a discussion on it. The cards, what was left, weren't discarded, because then they would be used in maybe the next session. Everything was basically covered.
Nobody got...
And plus, if you were having an issue which wasn't on the cards, then bring that into it. It's basically that this here's the folder, and you can see it. They didn't do anything. They give you the piece of paper, you had to write your name, and then you can imagine trying to slide that into that. And then it was every week, we're given what activities you've done, what activities was going to be next week, and that's the way it worked every week. And then at the finish was a motto. They says to me, would like people to do a motto. And because I was...
What's another slide? Good job, I know these slides. No. You had a motto, and they asked you to pick one, so you used one that you had.
They asked everybody if they had a motto, what would it be? Some people was picking improved memory, but because I joined the army when I left school, and they had one, overcome and adapt, and I thought, well, that actually suits dementia, because you've got situations and you've got to overcome and you've got to adapt.
Yeah. Audit assistant. So, being involved led you to do lots of other things.
Well, through the journey and through dementia, I've actually got involved in a lot in research. I've done research Bradford University, Sheffield University, Bristol, Exeter, Manchester, Salford, and then I joined groups Pathways.
Thank you.
The Face It Together group, the Today group, which is run by the Alzheimer's Society.
So is there anything else that you want to say about what,
Well, the thing is, when it was over, it was only 12 weeks. And when it was over, I actually asked, could I go back on it again? I actually benefited from it. My self-confidence was coming back. I wasn't isolated. I was starting to mix. At the start, I wouldn't tell people I had dementia. And this actually changed that. And I actually thought people what was diagnosed, this was actually the thing for them. Confidence.
Quite surprised at the results, really, weren't you?
I was, yeah. I was, yeah. Well, the only thing I'd think was, if it benefits one or two people, surely it works. So if one or two people's getting something out of it, it must work. I mean, the class, there might have been only 5 or 6 in there, but if 2 people's benefiting.
Okay, so I'll start with a question that was raised, I think that was addressed to myself before I asked the rest of the panel. So it was around this issue of why we chose facilitators, people to lead the programme, deliver the programme from the NHS rather than from voluntary sector services. Now, this was a decision that I took with Claire Craig, the person who also assisted me in developing the programme. A number of reasons for this. One was that we wanted to try and fill that gap that happens after people have received the diagnosis, and thinking about what NHS services ought to think about delivering or offering to people afterwards. So there's something about the gap in NHS services. There were other things, though. My experience of trying to undertake research of this kind, a trial, that is a randomised trial in the voluntary sector, proved very challenging in the past. So it was really hard to do that for a variety of reasons. NHS is more used to doing this kind of study and is set up to doing this kind of study. I do think that the programme itself is very is a good programme for voluntary services to consider delivering at least some aspects of it, if not the whole thing. So it was a practical decision. So I don't know where I don't think she's here now, is she, the lady who asked that question? Is she? But it was out of a practical but also past experience, which told me research in the voluntary sector is quite hard, this kind of research. So, okay, shall I go to one of the other questions now, which I will direct to one of the other panellists who I think fit to answer this. Okay, for Claire and Michael, I think, this question, it seems that a social environment benefits people with Alzheimer's, yet there seem to be few facilities and opportunities in some areas. What's being done to develop these facilities? Claire?
Yeah, well, I think there's lots of things being done nationally to develop facilities for people with dementia, but I can mostly talk about Bradford. So in Bradford, within the university, for instance, we've got our experts by experience group, and they're made up of people, Michael, and there's quite a few people sat in here, and so everything that we do in the Centre for Applied Dementia Studies, people are involved in our work. So we've got people who are involved in assessing the students' work, people who are involved in telling us what we should be researching and involved in actually co-producing research, etc. And also involved in devising training programmes for care staff, hospital staff, hospice staff, and co-delivering that with us. And although that's not a facility as such, it is something that people can get involved in and feel like they're actually, you know, being really a key part of that work. But then lots of the things in Bradford are run by third sector organisations. So I know that there's a new weekly cafe for people in Bradford that actually meets in Napoleon's Casino, and it's called the Bradford Memories Cafe. So it's based around, kind of loosely based on sporting reminiscence, but there are over 50 people go to that every week, and it's free. So it's kind of those sorts of things that are being developed that I know about at the moment, and you know, quite a lot of other things. I don't know if you've got any thoughts on that, Michael. I don't want to put you on the spot. Have you got involved in stuff? I think you're involved in a deep group, aren't you?
That's part of Face It Together group with the Alzheimer's Society.
Yeah.
And then involved with the Today group, the Pathways group, which is for young onset dementia.
Yes.
I actually think that's the problem. If you get diagnosed with young onset dementia, there isn't really a lot out there for people. And they seem to put you into groups where it's for older people.
So groups need to be specific to the needs of the people that are in them, don't they? And age-specific groups is a key thing that you found was a gap, but that's what Pathways does, isn't it? Yeah.
There's a couple of what I'd call methods question now. I'm going to ask Ben, one of our researchers, to answer. Maybe Jules can pitch in as well. One is, I was in the trial but didn't go to any groups. Why not? In the control group.
Well, to find out whether Journey Through Dementia has an effect or not, we need to compare it to a control. And for control for us as people just have what we call usual care day to day. So we, unfortunately, though we want to offer this to everyone and we think it's valuable to do so, better. We can't do that if we're going to work out whether this has an effect or not. So to do that, we have to split it up 50-50 to say these people get it and these people can't. That doesn't mean we won't roll it out in the future, or other more local services might do that, and it might become available. I can't say that it would. But unfortunately, to test whether it works or not, we have to split it that way. But regionality is very difficult because we could pick up maybe one site which has a slightly different change to another, which was, I guess, is what we mean by regionality. But we have to be cautious doing that because the number of people we're looking at. If in each site we were looking at 100 people, then we could make more understanding of perhaps something happens differently in Hartlepool compared to Bradford. But otherwise, we want to be a bit cautious about that.
Can I just ask a supplemental question to that, though? Some of your participants have been out of your region. And obviously, from health authority to health authority, there is wild variation in the offer available to people who are receiving a dementia diagnosis. And how is that going to skew what your findings are?
One thing we tried to do was to gather what we call usual care for all the areas. So we asked around all our sites what care provision is there at the moment, either voluntary or for the NHS, for people with dementia and their carers, and particularly post-diagnosis, where we fit in. And a lot of the things we were expecting to come out of that, but I think the point you get to there is important, because when we have people outside those little areas, we don't know exactly what they're getting. And we don't know exactly what treatments people are really accessing. So what we've collected is the usual care that people will likely get. And as you know, that can be quite patchy. And then we have the increased problem that if they are outside the area, we don't know. Now, our hope is, I suppose, and this is probably stepping a bit beyond my ability to know around clinical trials, so I'll say that. But when you get to this number of people, we hope that that's evened out. And we try and take away as much of that influence on our results as possible, but we can never do it completely. And it's just the nature of this type of research. We can't know what everyone does all the time. We do ask people when we go and see them what healthcare they've accessed in the last couple of weeks, last month, but that doesn't capture everything.
Lady should have been a researcher. That's a really searching question, actually. Yeah, there's no doubt that in some places, some things were being offered to people that were similar in some respects.
I think the question you raised is a key question that actually makes for huge trouble for the sort of work we do in research. And part of the reason for that is not just finding out what usual care is, but for this sort of study where you're wanting people to go out and enjoy their lives, there are a lot of people who somehow do that, yeah? And it's not even called health and social care, yeah? And what happens with our measures, technically, you can, when you go at 8 months, baseline 8 months and 12 months, ask people in that health economic questionnaire if you choose to. What you can't ask people, because you don't know, is what they were doing in the moment for the weeks and months in the summer and the rest of it, when they went off to families because somebody encouraged them to go and went to the theatre, etc. And I think the problem we then have is that we don't know so much about at individual level. And I think while statisticians do say it will even out, the fact of the matter is that it's an unknown, and there's a different sort of research methodology that we all need to be using to find out how it is that people can live as well as they can with this condition.
I'll follow that up with another similar issue, if that's all right. So if people attending said positive things, why haven't the results shown the same? I've spoken to people from Hull, I've spoken to people from Lincoln. I'd like their views, please, if possible. I know I'm putting you on the spot a bit, about what actually happened in those sites.
Us three facilitated at the Lincoln site. We had really, really positive feedback from our participants. In fact, a year and a half on, our group is still meeting of their own volition. Some of them travelled quite a while to come to our group as well. We had somebody that travelled an hour every week to come and attend the session, and they're still travelling the hour to come and meet up with their group. On our very last session, we had somebody who was on holiday in Morocco, and they were so desperate to not miss the session, they FaceTimed in to our last session. We had an absolutely amazing experience, I'll be honest.
I'll speak from Humber's point of view, and it's actually very, very similar to what you've just said. We have a group of people that are still meeting up at the same time that they used to meet up in Journeying Through Dementia. They've been on holiday together and on all sorts of trips together. So we know that it's made a life-changing difference to some of those people. And we're very lucky they spoke in a little video for us for a research conference recently. And their mood, everything has changed for them. So it's really disappointing that the outcome measures that we're using don't show that, because we know it's made a huge difference.
One of the measures that we did use, and I still want to know if we'd used it as a primary outcome, whether we would have found something, was a measure called Flourishing, and it's about all those things that people do when they get older and have a disability. And it showed some very small results, but statistically, it could have been random. And what I'd like to see in the future is how we can develop more measures that are going to really tap some of the concepts that we are trying to address, like getting people to enjoy life a bit better in the future.
Thank you. I suppose it partly picking up on Esme's point, really, which is it's really positive, the things that people have said about the intervention, how much they've enjoyed it or how effective they felt it's been. It may or may not be the case that Ben can elucidate some of the details about this, but I suppose I'm aware, having worked in dementia now for quite a long time, how much what we call treatment as usual has improved, and how much there's been a big development in memory services, which I know primarily has been around diagnosis, but there have been programs that have really pushed those kinds of services to think about post-diagnostic support and other ways that may not be journeying through dementia of building and creating or maintaining social networks or dementia-specific networks. So I do wonder if some of what's also gone on and is difficult for a project like this is maybe the treatment usual is not terrible. Maybe journey through dementia is just as good as that. So it's a point rather than a question, sorry.
Whereas in Rochdale, actually some things do go right in Rochdale. We have ongoing support, have a fortnightly, there's a post-diagnostic 8-week course, and then subsequent to that, there is a fortnightly group that one can join. And through that, the Birch Hill Hospital can contact them at any point if there's any problems. So I had a medication issue, and they could sort that out. Alzheimer's Society in our area also have a monthly cafe. 4 monthly cafes. Oh, there are 4 in Rochdale. And our own, the one that and the hospital connected one is fortnightly. And it's much more social. We don't go on rambles or anything, but it's social within the building. So in Rochdale, we're well catered for. I'm very grateful for that.
It sounds very much like it depends on what people are being offered, yeah, doesn't it? And the variety of that.
So I'm a researcher at Tees Esquire Valley's NHS Trust, and probably one of the researchers that you saw when you were collecting some of the data. And I just wanted to mention that actually it's really positive that there was some stories coming out from journeying through dementia. And actually, for me, I think it was because some of the outcome measures that have already been spoken about was that a lot of people were acting at what we call a ceiling level. So actually, people were scoring very highly on these questionnaires. So when we were re-asking them, there was no difference because they were already performing at the best that they could. So actually, it might not be that there's no difference. It might just be that actually the outcomes weren't sensitive enough to actually understand that. And the qualitative part of it might actually have more weight than the quantitative questionnaires that we got. I don't want people to feel like it was a waste of time or that it wasn't something that it wasn't positive, because it might just be that the scales aren't sensitive.
Yeah, just say you're absolutely right that what we did find that people who did join us in this study were relatively well. And that's kind of understandable in a way, because in these sorts of studies we have to recruit people as fast as we can, because there's lots of numbers to achieve, aren't there? So clearly those people who are feeling perhaps not so good aren't going to be as readily coming forward as those that feel okay. So that's another tangle. I think that I think the outcome measures is a problem. But we know that, and we have tried to apply for money for that, haven't we, Esme? We're still beavering away trying to convince people we need to do work on this. It's one of those that will happen. It's just convincing everybody that it's where they should be investing their money now. So we have tried that. It's definitely about the people who came forward. There is something about what's been offered already out in services. Oh, and I think the ability to be able to deliver it did vary across sites. So we've heard from very positive sites. I think there was some that weren't as positive as that. Depended on places, it depended on individuals as well.
I was just curious if any of the sites have any plans to keep going with the sessions.
Really, yes, people have asked this, what are the plans next? In the recommendations, you have to, in our report, we have to, the funders, we have to say what the recommendations are. My recommendations are that certain aspects of this intervention should be delivered in practice, but maybe the whole thing is too complicated, the whole 12, the group plus the one-to-ones. Maybe for some places that's too much of a stretch. But what I'm clear about is that people do need to get out and about. And I'm concerned as a therapist myself that things have become very kind of in institution based rather than getting people out and about. I think, which I sound very old now, we used to do it in the past. Don't know why that doesn't happen as much now, or perhaps it does, and that's just my kind of ill-informed view. But that's my view, it may be ill-informed. In Scotland, they are taking this forward within services, spearheaded by the therapy lead in the Department of Health there. So that is happening, interestingly. And that's partly to do with the work that my colleague Claire Craig, who couldn't be here today, is undertaking with Scotland. I think there's a lot that's very positive about the intervention, but maybe the whole thing, at the moment, maybe that's just too much. But I certainly think maybe individuals in practice should think about the one-to-one sessions and the benefits of those, and the benefits of helping people to achieve what they want to achieve and getting out in the community to help them to achieve that.
Just listening to what you're saying there, and everything you're saying is really, really good in theory. In practice, as I end from working for the NHS, that's not our core business. That's not something we would do. We would have to signpost. For all we think that, yeah, that's what we want to do and that's what we're in this job for. And then we're going on to social care and the financial implications that people are so reluctant to access community activities and things and getting people out and around. So I think that's where we struggle. Whereas we have to signpost, we can't continue to deliver this.
That's interesting, isn't it? Who's driving that? The decision that we, kind of can't do this, or I've got a problem with that. I think, in that if I was signposted something, if somebody said, "Why don't you come to whatever this exercise class?" I might think, Can I, can't I? Have I got somebody to go with? Do I know how to get there? What will it be like when I get there? I think it's really hard just to signpost people. Do people feel that without having somebody to go along with or somebody to help you kind of look at what's involved? I've got problems with that, really, signposting on its own.
Just adding on to what that lady was saying, very similar in our service. The service that I'm employed by through South West Yorkshire Partnership is assessment and diagnostic only. So the programme that we've done through this research, we were allowed to facilitate that as part of the research, but then any other groups that we have to signpost people onto, because as a service line, we are not allowed to provide that type of support within our service. And we have the same problem with that. We want to do it as occupational therapists. We want to do groups and get people involved because we're trained to do that, but we're not allowed to do it from a senior level point of view.
Another occupational therapist got a real issue with that. We need to be a bit more powerful than that. We need to say stop.
I'm wondering, well, part of the reason why some of you have allowed to do CST groups is because guidance says that is the evidence base. But you know, I'm just wondering, listening to people here, whether some of these findings can be the different levels of evidence base, some more real than others, because one of the biggest problems with these randomized trials is they give you what works for the average person. And yet as a therapist or clinician, we're much more interested in what's going to work for you and me and that individual in front of me. And I think there are other ways of selling evidence, and I think as clinical researchers, certainly with this study and others I've been involved in, that we should now step up and compete with this attitude that the only evidence that is worthwhile, because they started with the drug studies, and actually the drug studies haven't got on very well with these averages either, we are in trouble. So I think, given how long this JTD was conceived, some Gail thinks 2011, I think 2005, but never mind. Long-standing, thoughtful, patient-centered work, or people-centered work, is that we may need to start thinking as higher-level clinical practitioners of how to compete with what is evidence-based. Otherwise, these wonderful skills that some people, OTs and others, have been trained to do, will never get there, and the people who deserve them will never get them. So
I think if this was another chronic health condition, we would have very different treatment, and that's the political basis of health inequalities that people living with dementia are faced with every day. If this was a different health condition, there would be far more interventions provided by the health service as a matter of course, and not consigned to the dustbin of social care.